Hello, Lion. Hello, everyone. I was just seeing through the chat. Lalit, sorry, last time I got confused. I had put a wrong schedule in my calendar, so I thought the class was on Monday, and there's a mishap happened. So sorry for that. So we'll have today and tomorrow class. Today I'll be going with protoon-cogene concept, and tomorrow I'll be going with tumor suppressor. Good evening, Lion. Hope you're doing good. Good evening, everyone. So today we had seen about the classical 8 hallmarks of neoplasia in the previous class. That's a cell-surface growth factor. Good evening, Pratna. Your proto-oncogenes, your tumor suppressor genes, evasion of immune response, the Warburg's effect, Ayush, or the inflammatory, how to evade an inflammatory, your immune response, your limitless replicative potential, angiogenesis, and metastasis, right? In the next 8 class, we'll be going in the same order. Let's try and cover almost everything which is required for your Robbins, right? Good evening, Swati, Arya, and Bobby. So the first hallmark here, what we're going to discuss is the self-sufficiency of growth factors. If you remember the story of the kid and the cancer, we said that the kid never required growth factor, or the kid never required food, and the kid kept on growing. That's what we related to self-sufficiency of growth factors. So the gene which is responsible for the self-sufficiency of growth factors, we're going to name the one proto-oncogene. Okay. So first we'll understand what is normal, then we can go and understand what is abnormality here, right? So the gene is called as a proto-oncogene. So now just tell me what you like proto-oncogene. Like I said, it's a normal counterpart. It's completely a normal protein. There are lots of normal gene in our body, right? So a few of them, we're going to name them as proto-oncogene. Let's take a normal cell. Let's assume this is the normal cell here. Arya, we will be reading Robbins for sure. I hope you have the Robbins open with you. It's a bit elaborate, and what happens in Robbins is if you go line by line Robbins in neoplasia chapter, it becomes a bit difficult. So I'll go with the same concepts of Robbins, whatever is there in Robbins, and then definitely we'll try to relate to neoplasia chapter. At the end, we'll try to conclude with Robbins, because Robbins, what happens is when with respect to neoplasia alone, it's a bit elaborate and bit more in depth than what an undergraduate needs to know at this point of time, because there are few things in neoplasia I won't be talking in neoplasia. I'll be talking it a little bit later when you come to hematology or systemic pathology. That's why I'm not going with Robbins here. Fine. Hello, Danish. Okay, let's look at the normal thing. So let's assume I have a normal cell. A normal cell will require a growth factor, right? And let's take erythropoietin. That's a growth factor, and every erythropoietin or any growth factor will have its own receptor. That's a growth factor receptor. Once the growth factor binds to the growth factor receptor, I'll have transcription signals, transcription pathway, and it goes to nucleus, gives nucleus division, and it goes and divides, right? Thank you, Shiva. So all these are normal things which happens in a cell, and these things, all these are proteins, right? Growth factor is a protein, growth factor receptor is a protein, and all these protein will be controlled by few genes. Those genes are going to be named as proto-oncogene. This is normal. This is not abnormal at all. This is completely normal. So we're going to call all the genes which promote cell division. Any gene which is going to promote cell division, I'm going to call it a proto-oncogene. You can take any growth factor. Any growth factor for the matter is a proto-oncogene. The growth factor receptor is a proto-oncogene. The transcription signal is a proto-oncogene. Right? This is normal. Right? Now, since we are in the pathogenesis of molecular hallmarks of cancer, we need to identify why cancer happens, right? So let's say I have something called we name something called an oncogene. So oncogene is the abnormal counterpart. It's not the normal. Oncogene is nothing but mutated proto-oncogene, fine? Okay, I'm writing POC for proto-oncogene. Now tell me, it's a very simple question which I'm going to ask you. Normally, this gene's function is to promote cell division. For it to form cancer, the mutation should be gain of function mutation or loss of function mutation. This is true for every oncogene on the face of earth. It's the same thing, gain of function or loss of function, because normal function is to promote cell division. Obviously, when I'm going to have a cancer, all the proto-oncogene mutations, right? All proto-oncogene mutations has to be and only will be gain of function mutation. I can either call it a gain of function mutation, or I can use term amplification. The gene gets amplified. That's what amplification stands for. It's a little bit more, that's all. But when you have loss of function, normal function is cell division. When the function is lost, cell division doesn't happen. It will not cause cancer, right? It will cause cell death, right? So whenever I have a proto-oncogene and its counterpart oncogene, I have to have gain of function mutation. Only then it will cause cancer. This only will lead to uncontrolled or more cell division, which obviously can cause cancer, right? Remember this. This is true for every protooncogene, whatever we are going to learn, right? If you take Robbins, there's a huge table in protooncogene. I don't want you to remember everything. Few of them are required from a pathologist point of view, from a general medicine or an oncologist point of view. Those alone, if you read, that's more than enough, right? But one thing alone, the pathogenesis, I want you to read in detail, which is RAS. The most common gene mutated is RAS gene. It's a protooncogene. This is the undoubtedly most common protooncogene mutated, or I can call it a most common oncogene for sure, right? This alone will read in detail. Rest of it, like if you look at Robbins, they'll talk about tyrosine kinase. We will definitely read about tyrosine kinase, but we'll read during CML, chronic myeloid leukemias, the BCR-ABL. It talks about MYC. We'll read about MYC when you come to Warburg's effect. It talks about BRAF pathway. We'll read about BRAF pathway when you come to hairy cell leukemia, right? It talks about non-receptor tyrosine kinase and receptor tyrosine kinase, like JAK2. We'll read about JAK2 when you come to polycythemia. Does it make sense much there? And rather than reading everything here, if we read one concept and we understand that concept, we can easily extrapolate to any protooncogene whenever we read, right? RAS is undoubtedly the most common protooncogene. Let's see how a normal RAS functions. Okay. So we saw multiple things. We had growth factors, we had growth factor receptors, then we have signal transduction proteins. RAS is a signal transduction protein. It helps in signal transduction, or the transduction signals. They help in the signal transduction. That's a protein in signal transduction. We'll see what a normal RAS does. Let's assume this is a normal resting cell. A cell in an interface, a normal resting cell. I have the receptor here where there's no growth factors. When I have growth factors, I'm going to say the cell is going to divide. It's a resting phase cell. In a resting phase cell, RAS will always be inactive. Okay? RAS stays inactive in a resting phase. Only it's a protooncogene, right? When it's going to rest, it's not going to divide. It will be in the inactive state. So when I have growth factors, the growth factors come into play. Where the growth factor is present, or there's any signal for cell division, or in other words, I'm having a dividing cell. We have to understand what happens to RAS when it has cell division, a dividing cell. The same thing. The only difference is this growth factor receptor has got growth factors. The growth factor is bound to the receptor, right? So am I right in saying that there'll be signal transduction happening? Obviously, signal transduction must happen, right? So just one more information here. The inactive RAS has GDP. What does GDP stand for? If you remember ATP and ADP, same like that. I have GTP and GDP, right? Adenosine and guanosine, right? See, we have GTP and GDP, and inactive RAS has GDP, right? So when a growth factor receptor binds to this, it has to activate RAS. So this will convert an inactive RAS, that's the one with GDP. I have to activate it. Every activation in the world happens only with kinase. Which, Prabhat, please don't what? Okay, it happens with kinase. So here GDP will be converted to GTP. Tell me, Prabhat, right? Prabhat. Okay. So it'll convert to GTP. So it becomes an active RAS. Okay. It becomes an active RAS. Active RAS always will have GTP. Okay. It's just a conversion. I'm just going to add a phosphorylation. It becomes active. This activation should be momentary or it should be persistently present. The growth factor binding to receptor, is it momentary or persistent? Any receptor, any ligand, the binding is momentary or it will always be present. So always momentary, right? It'll come, it'll bind, it goes. Then it automatically divides, right? It comes, it binds, it goes. So once it binds, this will be activated. Suddenly it should be inactivated. Before inactivation, what happens is perfect, right? Hello Rahul, good evening. Hope your exams are over or exams are near. So once RAS become activated, this will activate two downstream pathway. We call them a BRAF or a RAF pathway, RAF pathway. Okay. Then we have one more thing called as phosphoinositol triphosphate kinase pathway. Sure, Prabhat, we'll look into it. I'm good, Rahul. Hope you're doing good as well. Okay, so I have phosphoinositol triphosphate kinase pathway. So this RAF pathway activates one more kinase called as MAP kinase, right? MAP kinase. All these are kinases, right? This phosphoinositol triphosphate pathway has few other proteins called AKT proteins. Ultimately, both of them will activate MYC gene. The MYC gene ultimately will help in cell division. This is what happens normally. Okay? This entire thing, whatever we read here, is nothing but a normal activation of RAS induced activation of any growth factor which is going to activate RAS. Always remember, whichever is crucial in my body will have its control. Like if you have a TSH, it will always have its control. T3 negative feedback, positive feedback, everything will have its negative and positive feedback. So this active RAS, like I said, it's a momentary response. Suddenly will become inactive. And the person who's going to make it inactive, you tell me what should you do to make it inactive? I have to make an active RAS, go to an inactive state again. What will I do? What should you do? I have to convert GTP to GDP, that's all. If I convert the GTP to GDP, automatically I'll make it inactive. So I have a protein called as GAP protein. GAP stands for GTPase activating protein. Okay. So once RAS activates the downstream pathway, GAP will inactivate RAS. That's the negative feedback there, right? Like that, I have negative feedback for everything. I have negative feedback for this. This guy will be negatively inhibited by P10. Okay. So it will suppress. Whenever I draw red, it suppresses. So GTP will be converted to GDP by GAP protein, right? Now listen carefully and answer. This P10 and GAP, these two guys, this P10 and GAP, they are promoting cell division or they are suppressing cell division? P10 and GAP. Who is online? Comment. It's fine if you're wrong. They are promoting cell division or suppressing cell division. They are P10 and GAP. They are suppressing because they are stopping the activation of RAS. That's your GAP, or suppressing by phosphoinositol triphosphate kinase pathway, right? So these two guys, perfect. These two guys are tumor suppressor genes. Okay? These two are classical tumor suppressor genes. That's the opposite of protooncogene, right? So now if I'll mark few things in red, RAS, active RAS is an protooncogene because it activates cell division. RAF is a protooncogene, again activates cell division. Phosphoinositol triphosphate kinase is a protooncogene, activates cell division. MYC is a protooncogene, activates cell division. Once MYC is active, it will make sure the cell cycle happens properly. For a proper functioning of cell cycle, I need cyclins and cyclin dependent kinases. That's required. That's also a protooncogene, right? In one step, we have understood there are multiple protooncogene. All these are normal genes. Whatever we read till now is normal, right? So what mutation should I have to have cancer? I should just have gain of function mutation. That's all, right? So when I have a gain of function mutation in the RAS pathway, it will result in cancer, right? So this RAS, so when I have a gain of function mutation, so let's say RAS becomes an oncogene. Oncogene is nothing but RAS is having a gain of function mutation, which means RAS is always active. Do I need a growth factor here or don't require? Do I need a growth factor or no? I don't require a growth factor, right? Because it's mutation. Mutation is reversible or irreversible? Undoubtedly irreversible, right? So it's always active, irrespective of the growth factor. They are going to cause an uncontrolled cell division. Okay. This is how RAS acts. Now, let's try to understand a little bit more. Since we are in the pathway, let's try to understand one more thing. So now here, can I say if gap is not present, let's assume gap is deleted, the gene is deleted. Will RAS ever become inactive or they'll stay in active state only? Do you think they'll become inactive or no? If there is no gap or GTP is activating protein, do you think they'll become inactive? They can't. They won't become inactive, right? So can I say a loss of function mutation of gap can also result in tumors? In other words, I cannot inactivate RAS, so it will always be active, right? So here, RAS activation will cause cancer for sure. At the same time, if you look at Robbins, this also will be written a gap inactivation or deletion. Okay, a gap inactivation will result in active RAS throughout because I cannot inactivate that. So automatically, this also causes cancer. Okay? There is a disease where gap is going to get inactivated. GTPase activating protein will be inactivated. Gap inactivation is seen in case of a neurofibromatosis, right? In case of neurofibroma, you have mutations in the gap in the NF1 gene. That's what gap is for. We have NF1. It's called as a neurofibromatosis. I'm sure you must have seen patients with neurofibromatosis. Also, we had discussed that in your genetics class as well, right? Neurofibromatosis is gap. The gap is a tumor suppressor gene. That mutation also can cause cancer. Protooncogenes mutation can also cause cancer, right? So these are, it's a single pathway. The multiple things in the same single pathway, activation or inactivation can result in a cancer. RAS, if you look at Robbins, there are multiple subdivisions of RAS. I want you at least to remember one subdivision of RAS. If not, if you can remember everything, more than amazing. But there are KRAS, there is HRAS, and there is NRAS. Never forget KRAS, because KRAS is very, very important for me. HRAS, not that important, because HRAS can be seen in thyroid cancers, bladder cancers, and renal cancers. For renal, thyroid, bladder, I don't look at genetics at all. As a practicing person, I don't look for genetics for kidney or your bladder or your thyroid cancer. Primary surgery, histopathology enough. But KRAS is seen in colonic cancers, colonic adenocarcinoma, lung adenocarcinoma, pancreatic adenocarcinoma. So for all these, I need genetic diagnosis. So if we have a surgeon diagnosing a colonic cancer without doing a KRAS mutation analysis, he will not touch the patient for treatment. The patient is affordable, I have to do it. That's by default. So a surgeon knows it, a pathologist knows it, I want you to know it, right? So HRAS, since it's theoretical, if you want to fill up your papers in your exam, go with that, but I would say not required. Thyroid cancers do have it, bladder cancers do have it, and a little of renal tumors do have it, right? Again, it's not required much. Then look at NRAS. N stands for a little bit of neuroblastoma lesions can have it, neurological lesions. Your melanomas can have it. Melanoma comes from neuroectodermal things. Melanomas can have it, and few of the leukemias can have NRAS. Again, this is not practically important for me. At one point of time, you will understand that medicine, more than reading, it's about knowing what to read. Because once I am not going to apply this to a patient, no one remembers. You also will not remember over the period of time. The only thing any practicing person will remember is KRAS. And if you look at most of the exams, questions come only in KRAS. Because that's what a practicing person remembers, and they are going to set up questions papers for you, right? So that's about KRAS and the exact thing of what happens in RAS, right? Okay, so RA is one of the most important genes which is required for us to know. And then there are few other important protooncogenes which I'll enumerate them. It's there in the table of Robbins. If you have the book of Robbins, try to underline these things or put a tick mark, because these are important from a diagnostic point of view. You'll have the first in the table. You'll have first column of growth factors. None of the growth factor mutations are required or applicable practically. Your PDGF, FGF, TGF, HGF, nothing is involved. Nothing is important for me to remember at all. Ignore that. When you come to growth factor receptors, in the proto-oncogene table of Robbins, if you have it by the side, first of growth factors is not required for me. So I'm not telling anything of that because nothing is practically applicable. When you look at the second part, you'll have growth factor receptors. I do want you to know few important growth factor receptors, right? So growth factor receptors, you have something called an EGF receptor family, epidermal growth factor receptor family, right? So we have EGF receptor family. In the EGF receptor family, I have ERBB1, two subtypes, right? And ERBB2. ERBB1's other name, actually the other name is actually well known, EGFR, and this is HER2. Both are must. You have to know both of them. If you remember, see in Robbins, it will be written alongside HER2, it's amplified. It's fine. Amplification or mutation, whatever it is, it's gain of function. That's all. EGFR is seen in case of one thing, don't forget, lung adenocarcinomas. It's only lung adenocarcinoma, and the most common mutation seen in Asian population and Indian population. HER2, breast cancer. You'll never forget breast cancer and HER2. When you come to surgery, you'll keep on reading it again and again. So it's something which will be there in your mind forever. Now might look, okay, very new name. It's very different. It's very, very easy. HER2, right? That's the entire gene's name. That's seen in breast cancer, sorry, fine. And then I have a proto-oncogene called as RET protooncogene. Okay? So the red protooncogene is mutated in multiple things, but at least want you to not to forget medullary carcinoma thyroid, pheochromocytomas, and a syndrome called as MEN syndrome, right? It is seen in MEN syndrome. MEN stands for multiple endocrine neoplasias. We'll read them when we come to endocrine chapter. That's the abbreviation or expansion of MEN, multiple endocrine neoplasia. And there are three syndromes in men. It is seen primarily in MEN2 syndrome. And under these MEN syndrome, it's multiple endocrine neoplasia. So as an easy way to remember, the tumors will be related to endocrine. It's MEN, right? So thyroid, especially in thyroid, I have medullary carcinoma thyroid, that's involved. Medullary thyroid cancer, and one more adrenal tumor, pheochromocytoma. So it happens in endocrine organs. That's all it is. It's medullary carcinoma thyroid and pheochromocytoma. You will end up in having in MEN syndrome. That's important for you to remember. Again, there's one more protooncogene is important. KIT. c-KIT or KIT, whatever you want to call it. c-KIT is important. c-KIT is seen in a tumor called as GIST. Few leukemias I do see, not much important, but don't forget GIST. Gastrointestinal stromal tumor, important for us, right? That's about of the growth factor receptors. In the signal transduction thing, that will be the next in the table. We already know about the signal transduction protein, one of them. That's what is a prototype for us. Okay. The signal transduction protein, the most important thing is RAS. In RAS, please don't forget KRAS alone. There are multiple things in below that. You have your NRAS, you have your HRAS, GNAC, and everything. Not much important, but don't forget KRAS, right? Same signal transduction protein, I have ABL. ABL is your non-receptor tyrosine kinase, right? ABL is nothing but a tyrosine kinase, not associated with a receptor. ABL is mutated in BCR ABL translocation, which is a classical Philadelphia chromosome seen in case of CML. That's one, right? Okay. Again, in the signal transduction protein, in the RAS family of protein, we saw something called as RAF, right? So a subtype called of RAF is BRAF. BRAF, two tumors, don't forget: hairy cell leukemia, melanoma. Again, there are multiple tumors with BRAF mutation, but these two I don't want you to forget at any point of time. It's very, very important for you not to forget this. If you look at Robbins, multiple other like colon cancer also will be written. A few other cancers also will be written. Thyroid cancer also can have this, but I am not going to do BRAF for colon or thyroid cancer as of now. Maybe in future if it's required, we'll learn them. As of now, not required to learn. BRAF means two tumors: hairy cell leukemia, diagnostic; melanoma, diagnostic and prognostic, right? Next, JAK2. JAK2 is also a signal transduction protein. Okay, JAK2 or JAK-STAT signal transduction protein. Again, don't forget only one: polycythemia vera. Polycythemia, it's a tumor of RBCs. Right? Vera is first, right? So polycythemia vera and few myeloproliferative disorders. If you look at Robbins, it will be written myeloproliferative disorders. When you go to WBC neoplasm, polycythemia vera is one subtype of myeloproliferative disorders. It won't be difficult for you at all, right? This is with respect to signal transduction proteins. The next category of proteins is nuclear regulatory proteins. Okay. The nuclear regulatory proteins, one thing for us is MYC. MYC has two subtypes. CMYC, seen in Burkitt's lymphoma. We will read about this, how exactly it happens when we go to Warburg's effect. And NMYC, again, if required, remember, not much important, neuroblastomas. The reason not important is as an undergraduate, you won't see patients with neuroblastoma. Fine. Rahul, pure red cell aplasia is exactly opposite of polycythemia, right? Pure red cell aplasia, you have a problem with no red cells. Polycythemia, the problem is excess red cells. It's exactly the opposite spectrum. Fine. Okay. So this is the nuclear transduction protein. Then last but not least is cell cycle proteins. So when I say cell cycle proteins, your CDKs. CDK is important. Cycle independent CDK4. Remember, one tumor at least, osteosarcoma. Again, not much important. Osteosarcoma's genetics is okayish, but not very important, at least for undergraduate. One thing is must for undergraduate: cyclin D1. Cyclin D1 and mantle cell lymphoma. This is common in an exam. Do remember that, right? So next question comes for you is, how do I remember so many subdivisions? Like, how do I remember growth factor receptor? How do I remember everything? Hello, Osama, I'm doing good. How are you? The exam's over? Thank you, Lilith. Hope your whole went well. Okay. So how to remember all these subtypes? It's simple. The first thing what we drew, this is what we drew first, right? We have growth factor. That's a chunk of protein. That's what I said to ignore from Robbins table. Growth factor receptors. That's where your EGFR comes, HER2/neu comes, all those secret and everything comes. Growth factor receptors, right? Next comes your signal transcription signals or transduction signals. That's where your RAS comes, ABL comes, BRAF comes, and everything comes. Then nuclear. The nuclear regulatory protein is CMYC. Then comes your cyclins. That's your cell cycle regulators. This is the same template what we read. And when we went to RAS, the same template. Had a growth factor, we had a growth factor receptor, we had all the signal transduction proteins, and then when we came to nucleus, we had nuclear regulatory proteins and cyclins. It's the same process throughout in every cell, right? Yes, Lion. One tumor can have more than one mutation for sure. Fine. Okay. I'll tell you what happens in tumors are. Let's assume that's about the protooncogenes, whatever we want to read about protooncogenes. I'll address Lion's question. Let's say I have a single cell. Okay. This cell got a random mutation. Let's assume EGFR mutation. So when it got an EGFR mutation, I'm going to have lots of division. That's what we call as an multi-step cancer pathogenesis. Cancer will never happen with one mutation. Okay? Yes, Rahul, if your proto-oncogene is getting activated, tumor suppressor gene cannot suppress beyond a point of time, right? A multi-step pathogenesis. Let's assume I got like so many cells. So what happens is these cells are very rapidly dividing, so there is a possibility I can have new mutations. That's a problem with the cancer. It will not stop with one, right? So let's assume when I have new mutations, what happens is this same cells with EGFR mutation will keep dividing. The black ones are the ones with EGFR mutation. That also will keep dividing for sure. It will not die. At the same time, I'll have a new set of mutations. Let's say that retinoblastoma or P53 got lost. This will have P53 loss. This I'm assuming random things, that's all. After few months or few years, when P53 is lost, can a new mutation happen? It can happen. So again, I'll have a subset of a clone which will have P53 loss. Okay. And one more subset having, let's assume, let's use a different color. Let's say it as E-cadherin loss. Okay. So if you remember in yesterday's class in the essentials batch, E-cadherin loss can help in the spread of a tumor. So it's a single tumor can have multiple mutations. This mutation which helps in the formation of the cancer, we call it a driver mutation. That's what we read yesterday. Driver is something which makes the cancer form. From a normal cell, it makes them a tumor. So these are mutations which is acquired in the process of growth or spread. So we call this an passenger mutation. No tumor will ever have only one mutation. If there's only one mutation, no, life would have been much easier. I just kill the mutation and take care of it. But it's always like this. One, more and more and more. So if I use an EGFR antagonist, only the black guy will die. The red guy will still survive. If I use some other thing to block this, the purple guy will still survive. It keeps on going like that way. I cannot stop that. Fine. Okay. This is what about this is called as a multi-step cancer pathogenesis. Almost every cancer will happen the same thing. It will be a multi-step pathogenesis. It's not a single event. Single event starts, but it keeps on adding together more and more and more. Thank you, Ayush. Hope you're doing good. Good evening, Priya. Okay, that's about today's class. I'm good, Priya. Hope you're doing good as well. Fine. So that's about proto-oncogene in simple words. Read whatever's there in Robbins. I think Robbins is like 4 or 5 pages of proto-oncogene. Just remember the names. Remember the RAS. The same template, the same gain of function mutation we'll be using in different proto-oncogenes at different point of time whenever we discuss systemic pathology. Fine. Okay. Any doubts? Do let me know. No, Pratna, that's for postgraduates of pathology. Please don't watch it. You might not understand that. It's not required for you. That's all. Lalit? I won't say some mutations large, some mutations small. Everything gives different survival advantage to a tumor. That's all. Let's say that you read first standard. The max of first standard is not useful now, but that point of time it is useful. That's all. Okay? From endocardium, we use endocardial biopsy when I'm going to have if I need a biopsy from the endocardium. I was at Karnataka Patil. Okay. Generally, I won't require biopsy. If required, I have to put a catheter via the femoral vein, go to the heart, take a subendocardial biopsy. That's how you have to do it. Rahul, tongue is generally a part of systemic amyloidosis. We take the abdomen fat part to prove it's a amyloidosis. That's all. We don't take a tongue biopsy. Fine. Okay, great. So see you guys in the essentials batch. So hopefully we'll be completing neoplasia chapter, and I'll take care of all of your doubts in neoplasia chapter in the essentials batch. Right? Bye bye. Thank you.